welcome everyone, and thank you so much for spending this time with us today. My name is Dr. Suzanne Campbell, and I'm an associate professor of nursing at UBC Vancouver campus. Today, we are welcoming as our visiting scholar, Dr. Janet Currie, and looking at whether domperidone off-label should be reconsidered for the treatment of low milk supply. I would like to take a moment to acknowledge the land that we are calling from. UBC's Vancouver Point Grey campus is situated on the traditional ancestral unceded territory of the Musqueam people, and the Okanagan campus is situated in the territory of the Sela Okanagan Nation and their peoples. I myself am calling in from the unceded lands of the Semi-Amu, Musqueam, Tsleil-Waututh, Stolo, and Squamish nations, all of the Coast Salish peoples. And I would like to hand this presentation over to Dr. Janet Currie. Welcome.
Thank you. Thank you very much, everybody for attending, and also thank you to the School of Nursing and to Dr. Suzanne Campbell for helping with the slides today. I also want to acknowledge my work within Treaty 6 territory and within the Métis homelands and Métis Nation of Alberta Region 4. I acknowledge this land as the traditional territories of many First Nations, such as the Cree, Dene, Stoney, Saulteaux, and the Blackfoot peoples. Thank you. So next slide, please. So I have no actual or potential conflict of interest in relation to this topic or presentation. Next slide. So today I want to talk to you about the importance of breastfeeding, which I know you basically understand, and I'll talk a little bit more about that, and low milk supply, the types and causes of low milk supply, what we know about it, the prevalence of domperidone use for low milk supply, off-label prescribing, domperidone safety and efficacy, and then ask the question, why is domperidone use for low milk supply so high in BC? And then finally, whether we need to reconsider the use of domperidone to treat low milk supply. Next slide. So in terms of the value of breastfeeding, I think this has to underscore everything I say today. There is a strong global consensus on the importance of exclusive breastfeeding for at least 6 months and then up to 2 years with supplementary solid foods. And we know, and the data keeps coming in terms of the profound health benefits of exclusive breastfeeding for infants into adulthood and for parents as well. And this is a view that Canadian parents accept, because 90% of Canadian parents intend to breastfeed, and they do go on to initiate it. But by 3 months, the rate of breastfeeding drops to just 52%, and by 6 months, there's a precipitous drop to 14.4% of mothers who are exclusively breastfeeding. And when we look at all the data from Canada, from the US, and internationally, a mother feeling she does not have enough milk to feed her baby is one of the top 2 reasons parents give for stopping breastfeeding early. So it's a very important public health issue. Next slide. So we're still finding out and defining low milk supply, but usually it's broken down into 2 types. The first is called primary breast milk insufficiency, where physiological barriers affect lactation. And in the mother, the most common is hypoplasia, which is diminished glandular tissue in the breast, issues like endocrine problems, like polycystic ovarian syndrome and infections. And in the infant, issues like facial abnormalities, sucking impairments, and other problems such as cardiac problems. We don't actually have a firm number on the prevalence of low milk supply. Various manuscripts in medical literature will say 5%. of problems with lactation are related to physiological problems, sometimes 1%, and up to 15% in some groups that are more vulnerable. But we do know from breastfeeding experts that physiological conditions are not always a barrier to breastfeeding. So when thinking of hypoplasia, there are many situations where there is low glandular tissue in the breast, but breastfeeding can still take place, sometimes with supplemental feeding, but it's not a complete contraindication for breastfeeding. Next slide. So this means that most cases of low milk supply are what we would call secondary breast milk insufficiency. And this is where there are non-physiological factors that affect lactation. There is an effect on lactation of these issues, but there is no true organic cause that can be found. And so I've listed 5 issues that came up in my research. One is, and all of these are discussed in the literature as well, a premature diagnosis of low milk supply. And that can be related to unrealistic expectations of postpartum weight gain in the early postpartum period in breastfeeding babies. And I found in my research, the mothers who had used domperidone told me 50% of them said they were diagnosed with low milk supply 2 to 4 days postpartum. And that is really too early to establish whether lactation is established or the milk supply is underway. And that's reflected also in the literature. And one of the issues I discussed is whether weight gain of formula-fed infants is used as a standard for normal postpartum weight gain. We know that formula-fed infants gain weight faster and more consistently than breastfed babies, and sometimes breastfed babies are slightly, there's more variability in weight gain, and sometimes breastfed infants are kind of outliers in terms of the time needed to gain weight after birth. And of course, once low milk supply is diagnosed, in many cases, this means the introduction of formula and pumping. And these technologies can also affect lactation. And one of the issues that's very strongly reported in the research is the lack of breastfeeding support and information to mothers prior to birth and in the postpartum period. And that would be information about techniques like proper latching, changes in the breast so that mothers who feel they don't have enough milk may be perhaps not understanding what changes in the breast take place, and the baby's sleep and feeding needs, how much the baby needs to eat, and also whether certain behavior indicates hunger. For example, does fussiness always indicate hunger? And there's quite a strong literature on the need for more information among breastfeeding mothers on some of these issues. And in my study, 50% of the mothers were discharged within 24 hours. And that meant there was kind of a gap between hospital-based information and support on breastfeeding and community support. Public health nurses did step up to the plate, but all the mothers commented on a reduction of support services for breastfeeding in their local public health center. Next slide. So how much is domperidone being used to treat low milk supply in BC and Canada? Well, the first study that was done on this in 2016 looked at the rates of domperidone use between 2002 and 2011. And there was quite a dramatic increase of 8 to 19% among term births and 17 to 32% for preterm births. And this study also showed that for initial prescriptions, The median daily dose level increased from 60 milligrams a day to 80 milligrams a day, and the duration of use increased. And all the regulatory authorities that speak about or approve domperidone for any use state that 30 milligrams a day is the maximum safe dose. And I'm going to come back to this a bit later. So you can see in this study, there was a considerable number of cases that were using doses higher than 30 milligrams a day. Now, the second study was a slightly different study. It was looking at the effect of Health Canada advisories, and it was wider. It included Alberta, BC, Manitoba, Saskatchewan, and Ontario, and some of these provinces are low users of domperidone. And this study also found there was an increase from 7 to 12%. BC and Alberta had the highest rates of use, and the median dose was over 30 milligrams a day. They didn't look at doses more specifically, and I was unable to acquire the BC data, but again, showing a pretty consistent growth in use of domperidone. Next slide. So just to back up a little bit, domperidone is prescribed off-label. And to just review what off-label means in Canada, in other jurisdictions, when a drug is approved by Health Canada, and that is through quite a rigorous clinical trial process, it is approved for a specific indication, population, dose, or method of administration. And then after it's approved for these issues, it is prescribed for use not approved for this indication, population, dose, or method of administration. And this is off-label use. 11% of all prescriptions in Canada are prescribed. 11% of all prescriptions are off-label prescribing, and it's higher in specific drug classes. So looking at a drug class like psychiatric drugs, 26% of all psychiatric drugs are off-label prescriptions. So they weren't approved for that use or population. One of the real concerns is that 79% of the drugs prescribed off-label lack strong scientific evidence for these off-label uses. And finally, there's inadequate post-market surveillance of off-label uses in Canada. Post-market surveillance is once the drug has been approved. For example, there is a lack of systematic adverse drug reaction monitoring of off-label uses. Most monitoring done by Health Canada for safety really only applies to approved drugs. So there's a big gap there. And when Health Canada issues a warning, the warnings do not usually include references to off-label uses. Next slide. So in Canada, domperidone is approved for gastric motility problems. And that was usually for population groups such as older people with Parkinson's disease who had gastric problems related to the drugs they took for Parkinson's. And it's used more commonly now for gastric problems in those undergoing chemotherapy. It's not approved for treating low milk supply in Canada, and it's actually not approved in any jurisdiction in the world to treat low milk supply. And it's not used in most jurisdictions. For example, no country in the European community uses it for low milk supply. Interestingly enough, it is not approved for, domperidone is not approved for any use in the United States. And its procurement, importation, or use in compounding pharmacies is prohibited in the United States. So a person that imports it from another country in the United States and uses it actually violates federal regulations in the United States. But domperidone to treat low milk supply is widely discussed and promoted online through breastfeeding support sites in Canada and in the US primarily. And in this world, in this online world, there's a lot of discussion about how to get Domperidone, and it's usually purchased through Canadian and overseas pharmacies, for example, in India, Thailand, and China, in bulk. My personal view of this is that this is a very common way of obtaining it, and yet we know very little research-wise about this use. Next slide. I'm going to talk in the next few slides about Domperidone risks and the data that we have on its effectiveness. So first, to talk about risks, there are two main risks of Domperidone, and this would be Domperidone for any purpose, and it would apply also to its use for low milk supply. And the first is cardiac risks. Domperidone can induce Qt Prolongation, which is a disorder of the electrical activity of the heart. And the second is antipsychotic withdrawal effects, which has kind of become more prominent in the last few months, and I'll explain that a little bit more. Next slide. So just to review Qt Prolongation, the heartbeat is regulated by the electrical impulses of the heart. And if you see this diagram, it's obviously ECT and EKG, sorry, and you can see the interval between Q and T is the QT interval, and this is where there is the QRS phase is where the ventricles contract, and that's in the lower chambers of the heart, and that's called depolarization. And then the T phase is where the ventricles relax, the repolarization stage, which was the preparation for the heartbeat. So obviously this is a very important function of the heart. When the repolarization stage, there's a small delay in it that can lead to a long QT interval, which can lead to different types of arrhythmias and the risk of sudden cardiac death. Next slide, please. So we know that there are two types of QT prolongation. One is congenital and the other is acquired. And the acquired is primarily drug-induced by QT prolonging drugs, drugs like Domperidone. And what are the risk factors for this to happen? Well, first of all, taking a QT prolonging drug increases risks, but the concurrent use of QT prolonging drugs, in other words, taking more than one QT prolonging drug at the same time, increases risks. Higher dose levels and longer use of QT prolonging drugs increases risks. And when I talked to you about the studies that have been done in Canada, indicating that dose levels are increasing. And in the first study, there was a longer use of Domperidone. So these could be risk factors. Domperidone is also contraindicated with CYP3A4 inhibitors, and those are enzymes one would find in grapefruit and grapefruit juice. So other risk factors are female sex. Female sex is an independent risk factor, older age, cardiac history, and electrolyte problems, which can be found in people that are experiencing eating disorders. Next slide. So just to go back to one of the risk factors, which is the concomitant use of QT prolonging drugs. And there are many, many common drugs that are QT prolonging. And I've listed a few of them here. Common antibiotics, such as the class of fluoroquinolones. Antidepressants, here are some of the most commonly used antidepressants. Antifungals, antipsychotics, and methadone. And I just selected a few. But if you go on to this site, it's an excellent site for an exhaustive list of these drugs, and they're constantly being added to. Next slide. And we know that, the literature tells us that concurrent use of QT prolonging drugs is quite common. In the most recent study of Domperidone, the one that looked at 5 provinces, almost a third of the people in the Domperidone population group were being prescribed drugs with a known risk of QT prolongation, and 13% were being prescribed drugs with strong and moderate CYP3A4 inhibitors. So this is a problem, the lack of screening of risk factors in terms of people who are being prescribed Domperidone. And in my interviews with mothers who use Domperidone, 50% of them told me they got no screening before being prescribed the drug, and that includes cardiac history screening. And only 2 out of 18 were asked about taking other QT prolonging drugs. In fact, that was a big surprise to the women I interviewed. They didn't know about this issue. Next slide. So I'm just putting the most recent Health Canada safety warning here. It reiterates many of the things I've already said. The warning came out in 2015, but last year Health Canada sort of reiterated the importance of this warning. They didn't issue a new warning, but just repeated the kinds of concerns. And again, they stated in this warning in 2015 that the maximum dose is 30 milligrams a day and for the shortest possible duration. And that is a concern because many of the women I interviewed, and other data indicates this too, that mothers are being prescribed this drug sometimes for many months. Next slide. So the issue that I really want to bring forward today too is the information, more and more information we're receiving on antipsychotic withdrawal symptoms from Domperidone use. Domperidone is an antipsychotic, but it isn't prescribed for psychosis and schizophrenia. And so most prescribers, and that includes physicians and patients who are prescribed Domperidone for low milk supply, are unaware that it is an antipsychotic. But recent case studies in the literature and patient reports are telling us that some women are undergoing quite severe withdrawal symptoms when they discontinue Domperidone abruptly. This can be very intense at high doses, but it can occur at the dose of 30 milligrams a day. Adverse effects are common to antipsychotic withdrawal: weight gain, intense anxiety, panic, dizziness, loss of balance, loss of appetite, dry eyes and mouth, gastric problems, akathisia, confusion, insomnia, in some cases, symptoms of psychosis. Symptoms can occur at a lower level during normal use. Patients who have discontinued abruptly and run into these withdrawal symptoms at a moderate to intense level may face a tapering process of small reductions lasting months or years. And a secondary concern is, and I've already seen this talking to patients who are undergoing this, is this may lead to what we call a prescribing cascade, where they will get more drugs prescribed to try to help them with their withdrawal symptoms. And I've spoken to several mothers who are getting benzodiazepines and other antipsychotics in the attempt to try to help them with their withdrawal symptoms, and it's really complicating their lives further. Next slide, please. So I'm including in here a case study that was reported in a family practice journal in the UK by a physician who's a neurologist and very well known for his involvement in psychiatric drugs. He described a patient who had come to him. She had decreased domperidone abruptly. She'd only been using 30 milligrams a day. And just the second paragraph, the symptoms she developed: severe insomnia, akathisia, severe anxiety, difficulty swallowing. She was very depressed and felt she was putrefying inside, developing a delusion she had lost her internal organs. She developed severe cognition and memory problems. She was previously active as a lawyer with no psychiatric history, and she had lost all motivation and stopped taking care of herself. She planned suicide. On March in 2013, she was prescribed olanzapine, an antipsychotic for the psychosis, but only took an occasional dose. She was separately assessed by 9 consultant psychiatrists, but no clear diagnosis was established. 10 months later, she was still having withdrawal effects. And I include this not to say that everybody who takes domperidone will experience this, but certainly I've talked to many women in the last couple of months who have experienced these or very, very comparable situations where they were unable to take care of their babies because they were undergoing severe effects. Many of the women had gone off domperidone abruptly or quite quickly following what they thought was a safe withdrawal process. And it really means rethinking this and perhaps going back up in dose and withdrawing very slowly, but it's definitely a very devastating experience to go through this. And among the women I interviewed, 2 of the 18 women had undergone these effects as well. Next slide, please. So I think one of the burning questions here is, does domperidone increase milk supply? What does the literature tell us? And in fact, the evidence from randomized controlled trials, the gold standard of research, is weak. Look, there's been low study enrollment in the RCTs that we have. 4 of the trials on preterm infants, which looked at domperidone versus placebo and effect on milk volume, had only 109 participants in total. So they didn't have a lot of power. We don't have any studies that have done more than 1 to 2 weeks of tracking of milk volume. In several preterm trials, milk volume did increase, but the results were modest. Only 2 trials have compared doses of 30 to 60 milligrams a day, and there were only 17 participants in those trials. And there was no difference in the milk production with the 2 doses. And there's no data showing that higher doses work, higher than 60 milligrams a day work either. We just don't have the data. And the results for term births were of low quality. 4 of the 6 trials started domperidone 24 hours after birth, which is an inappropriately early time to start looking at milk supply, because the mother has not had a chance to establish, to have her milk supply established. There has been a limited collection of adverse drug reactions in the clinical trials, and the safety of domperidone for infants has not been clearly established. Next slide. So I've just got a couple more slides, and one of the questions I wanted to ask is, why is Canada one of the only countries to prescribe domperidone for low milk supply? Australia is another country that uses it, but it's not highly used in the rest of the world. And this was noted in a study on domperidone use in England. There is a really tiny segment of the population that uses domperidone for low milk supply. And this researcher made the following comment: "It is unclear why postpartum domperidone use is extremely high in Canada as compared with England. Canadian prescribing practices may have been influenced by Canadians leading clinical trials on domperidone use and many Canadian experts and organizations that have been proponents of domperidone use." Now, the first part of this explanation does not exist. There was a Canadian clinical trial that was planned called Empower, but it never, it started the first phase, but it was canceled because they couldn't recruit enough people to participate. So we've never gotten any answers from that trial. But I think the other question, the other explanation that many Canadian expert leaders and organizations have been proponents of domperidone use is a fact. So I've categorized that under the role of key influencers, and I'm going to talk about that a little bit more because I think it's very germane to the Canadian experience and use of domperidone. But I think the second point too is that I think healthcare providers, and I'm including physicians, midwives, lactation consultants, there are many that believe in domperidone's safety and efficacy, and they do want to help distraught patients who come to them feeling that, being very worried that they're not producing enough milk. I think there may be some lack of familiarity with or confidence in non-pharmacological methods to treat a low milk supply. I think some of my survey results with physicians suggested that. And I think that Health Canada has done a very poor job regulating off-label use so that we're not getting the information we need to assess safety and efficacy for off-label uses in general. So next slide, please. So I'm going to talk a little bit about the role of key influencers, because that has been a factor in the research I've done and in the exchanges with breastfeeding experts and people that support people who are breastfeeding. There has been a long time breastfeeding advocate pediatrician in Ontario who has a very large following and has done some excellent work in terms of providing support to breastfeeding mothers, how to improve positioning and latching. So has done some really good work and has written a textbook on this issue. But this person has been recommending doses of up to and sometime over 120 milligrams a day or more in some circumstances. More important perhaps is that several years ago, he co-authored an unpublished, non-peer-reviewed consensus statement called a consensus statement on the use of domperidone to support lactation. And this consensus statement minimizes the risks of domperidone and also the validity of Health Canada's warnings on the drug. And what concerns me about this consensus statement was very widely distributed, not in the literature, but on breastfeeding support sites, both North American and internationally. And when I asked, when I did my survey of physicians and with midwives, this consensus statement was the top source of information used on domperidone's safety and efficacy for midwives. In other words, when I said, what is the best source of information for domperidone's safety and efficacy, this was the #1 source noted by midwives, and it was the second most useful source identified by family physicians. So it carries a lot of weight. And I wondered if it could have shaped the views of the family physicians and the midwives that I surveyed. 80% of the family physicians and 84% of the midwives thought domperidone had no or minimal risks to mothers. Next slide. So just to sum up, I asked myself a number of questions at the end. One of the things to remember is the off-label prescribing is is really recommended for health conditions that are life-threatening or very serious, and where there are no other or very few other effective drugs to treat it. First of all, low milk supply is not a life-threatening condition. It's a very important condition for mothers and their babies, but it is not a life-threatening condition in the way that other conditions can be. And more important, there are other effective non-drug treatments which help build milk supply. And there's a wealth of literature and a wealth of evidence that these support information strategies work. The quality of evidence for Domperidone's effectiveness is weak. The benefits do not outweigh the potential risks, in my opinion, which can be very serious. And there's a lack of post-market oversight for off-label uses, so we can't be assured that domperidone, when it's used for low milk supply, is being sufficiently tracked by Health Canada. We can't be assured that they are identifying safety signals because they are not collecting adverse effects of domperidone for low milk supply in a systematic way. And last but not least, one of the recommendations for off-label prescribing is that there should be full informed patient consent before a drug is prescribed. And I found that the mothers I interviewed were not fully informed of domperidone's risks and benefits. So I think that would be a very important thing to include. So that's my presentation. And thank you very much for attending and being interested. I'd be glad to, I think Suzanne is back, so she's going to be moderating the questions. I'll be glad to address anything you have questions and concerns about.
And I apologize, my internet goes in and out and I just totally got kicked out. I am back here. Heather, thank you for taking over the slide components. And we have some good questions in the question and answer piece. I did not mention in the very beginning that we are recording this, but none of you are being recorded. It is anonymous. You will not be seen or heard unless you want to be. I see that there is a raised hand, but I'm not sure if that's just on my presenter mode. And when I look at participants, it looks like I can allow you to talk. So if we get beyond this, feel free, but otherwise putting things in the question and answer would be ideal. The first question, Janet, is what the role of the IBCLC is in the cases that you had mentioned, because boosting up the prolactin level alone by domperidone with that as an ingredient for the production line without improving the other things that affect the oxytocin signal for the mother from the baby is a very incomplete view. And I think that fits with the research that you did.
Yeah, I mean, I don't know, you might want to comment a little bit on that, but the point I was really trying to make is that what worries me a little is that sometimes when we look at pharmaceuticals, and I'm not condemning pharmaceutical treatment at all, but when we look at that as a solution, it can be part of a medicalization approach. And so the other approaches that support the development and stabilization of milk supply kind of go by the wayside a little. And it certainly was reflected in the mothers' comments to me that they felt in general, they got a lot of contradictory advice on breastfeeding. There was a lot of fear mongering about low milk supply that scared them and made them very anxious and wanting to do something right away. And another issue was they didn't feel they received enough information about the challenges of breastfeeding. They were all go-getters and they'd taken courses, but the stress was on challenges of birth, and they felt they had a kind of a romanticized view of breastfeeding, and so when they ran into challenges, they got anxious very quickly. And I mean, I breastfed all my kids, so I remember being really anxious in those early days. And one thing was said to me that threw me off. I was very vulnerable to it. So I think those other things, the importance of those cannot, I think they have to come first. And I worried about in my mothers that I interviewed, those things kind of got left behind. Although in general, the women felt very positive about the help they did get. I don't know if that's kind of a long, involved answer to your question, but.
Well, and I think the focus on the medicalization is very important. When I look at the other two questions here from Michelle and Gisela, and I'm not sure, Janet, if you can see them as well. One's about the cardiac risk, whether it's domperidone use oral or IV. I think it was only oral that we were talking about. And what other non-pharmacological treatments were studied. It's really whatever came out in the interviews with the mothers, but you were focused in your dissertation, which is available on the UDC Circle site if you want details. You did interview the doctors and midwives as well in a survey that asked a little bit about how they diagnosed low milk supply, and then what type of what they did prior to putting mothers on domperidone, trying to get at the EKG and the other choices. So I wonder if it would help the audience. We did have 74 people signed up and 35 people here today. So thank you all. Huge representation from the BC Lactation Consultants Group and other colleagues across Canada. So thank you for being here.
Yeah, we did ask healthcare providers what they did, and they did do a lot of support. They did, reassurance. They did techniques such as proper latching. The midwives were a bit higher on that, I think, in terms of the women themselves. Almost all of them used different kinds of galactagogues, nutritional, everything you can name. They tried supplements. They went to, many of them hired lactation consultants. They, when they were trying to develop their milk supply, they did get involved in very, to them, grueling pumping and domperidone use, feeding with breast milk, with pumping, with formula, quite extensive schedules. They really tried most things. None of them used another medication. They just used for pharmaceuticals, they just used domperidone. But in terms of other non-pharmaceutical approaches, they really did use pretty much everything that they knew of or could think of or were advised to use. They had midwives, and midwives also went over latching and positioning and resting, and so there was a huge array of supports that we're using.
We've got quite a few other really good questions, so I'm going to start moving us along so we get to answer them all. One is about how many mothers actually had a problem with cardiac issues with domperidone, and earlier on, Maggie had asked whether the information you had on the rates of domperidone use across Canada, you looked at the difference in prescribing in time periods. Do any studies give us the actual rates of use?
Well, I mean, the BC study did look at the percentage of use of domperidone among mothers of reproductive age that were using the drugs. So that was that was in the first study. The rates of use, that was the rates of use in those 5 provinces. If you're asking me nationally, so it's complicated to figure out because domperidone is prescribed for other reasons. For example, I know that 35,000 people got domperidone last year in BC. So you'd have to extrapolate the people that you think are using it for low milk supply, and that's a complicated endeavor. But the first two studies did give prevalence of use among breastfeeding mothers of domperidone, yes.
And what about the number of mothers who've actually had cardiac issues with
Well,
domperidone?
that's a very interesting question. Because domperidone use, initially was primarily used for approved uses, so would be mainly in older people, say with Parkinson's disease. The growth in domperidone use for low milk supply has not been that well studied in terms of cardiac events. There have been two small studies. One was done in BC, and they did find an association between ventricular arrhythmias and domperidone use. But the study was small and lacked access to some records. And the second study also, the one that was done last year, also tried to look at this question, but again felt there was a strong likelihood of domperidone for low milk supply contributing to cardiac events. It again didn't feel there was sufficient information to establish that. There are some broader studies showing in France, for example, showing cardiac issues among younger people. And there are some suggestive issues of people in Canada, that one person who did die from a cardiac event. But the data is in its infancy. And I think we need some bigger studies that have more power and can access all the records. So I think we'll see those in the next little while, but there are two smaller studies.
And I think,
and I'd be glad to send the references for them if someone wants to contact me. I can send the citations for both of them.
Yeah, maybe Heather, I don't know that last slide with our contact information. Maybe we could just type that into chat. But I'm thinking that part of the complexity is that it doesn't have to be reported because it's an off-label use. And so it's probably underreported. And what we've noticed that I think you mentioned already was at Dr. Hale's risk center in Texas, the number of reported psychotic episodes trying to go off it. And again, that the risk factors become greater with what Janet mentioned about if they're on anything else that affects QRT, if they are taking higher doses, if the duration is longer. So all of those factors, and part of us wanting to do this presentation was to just get the word out there so that consumers and practitioners are informed and that the right questions are asked and that the non-pharmacological areas are mentioned. One of the questions is about the role of pharmacists in the use of domperidone. I know Janet has some good insight into this. Are they aware of potential risks? Is this education not being passed on to patients? And actually, I think the pharmacists that often catch it and ask about it.
Pharmacists know well that you shouldn't be taking a QT prolonging drug with domperidone, and I've seen readouts from pharmacies on that. In fact, there were two cases of people, mothers that I interviewed, where they believed that they should be taking high doses of domperidone. And when they tried to fulfill their prescription, the pharmacist refused to fill it, said it was too high and it could kill her. And she went back to this prescribing authority and convinced them to speak to the pharmacist. And she was prescribed it. And in a similar case, a person who was taking it, the pharmacist wouldn't prescribe it, and the prescriber agreed, and she just doubled up her dose. So there was a and I'm not in any way blaming these people. I think they they felt very strongly that they needed to take doses of 120, 150 milligrams a day. They really, really believe that, but there's no data that demonstrates that. So I think it's a very profound issue for new mothers. And that's the basis on which I did my research, because I think that you're right, we need to be discussing it more, and we need to be doing some really good research on it, and we need to know what's going on in the online community as well. Because when you order from an online pharmacy and you do not have a doctor in your country that is experienced with this, I think you're at risk, you're more at risk. And your point, just that we don't collect adverse effects on off-label uses. So, you know, if someone has a problem, we are missing some of those safety signals. And Health Canada is concerned about this. I mean, because they're writing more and more about domperidone for low milk supply. So I think some of the protections aren't there.
And Janet, we still have about 6 questions and 7 minutes left here, but I'm consolidating some of them. And someone has said, you know, it's the cynics who within the lactating community might think that the formula industry is involved with the lack of approval of domperidone. And I don't think that's the case at all. You know, managing low milk supply, the effective sleep training, Gislan, you brought up again, and definitely it fits in with the medicalization components that we've been talking about. I do have a couple of questions about the herbal galactagogues, and that is sort of outside the scope of what Janet researched, and I'm not sure how comfortable she is, but it's what are your thoughts on efficacy and safety of fenugreek and blessed thistle? And someone else said, well, we also need to be sending the message that research has not been done, and there are potential risks for herbal treatments as well.
Yeah, what I did was I was simply asking mothers what other approaches they used, and they did use herbal and food-based galactagogues, or those having galactagogue effects. You know, it was a majority of women. They did comment on effectiveness, and they didn't find they were effective, and that stimulated the use of domperidone as well. I think it's a really interesting comment about the formula industry preventing the approval of domperidone. I think that's not likely for a couple of reasons, because it's not going to come into Health Canada's approval process. I'm not saying Health Canada's approval process is perfect, but I don't think that would come in. But also, if a person, in my study, if a person was diagnosed with domperidone with low milk supply, they were told to use formula. It's part of the mix, right? You know, so it's an interesting point. And in terms of sleep training, I think, is that the point you were making? Is that in terms of people maybe not understanding sleep needs or sleep patterns of babies that made them feel that their baby was hungry, which you know has been described in the literature. Is that the comment that was?
Many of the low milk supply linked management issues of breastfeeding can also the effect that sleep training can have on the milk supply overall, and parents being very vulnerable because they're sleep deprived.
Absolutely.
And I think some of the really other interesting comments, and we have both the chat and the questions going on here, but the need for better breastfeeding support, which is what we're advocating for, experts who know and understand a quick fix prescription, which remember the tension that our healthcare providers, and I felt Janet did a really good job, as you know, we're all, many in the room are healthcare providers, we don't want to see parents stressed. We know that being stressed and anxious and nervous about feeding your baby messes with the whole physiological process of letdown and milk production. And of course, if even placebo effect, taking that domperidone makes them think they've got more milk, then power to it. And again, we know that 33% of the time, placebo could have a positive effect regardless.
Yeah, and I think there's so many aspects of medicalization. There's a wonderful paper by Torres, who's a lactation consultant, Torres, on medicalization of breastfeeding, and you know, the more specific and detailed tracking of breast milk supply, that, you know, and I talked about this in my thesis, that there are actually apps now which can measure your baby swallow and swallowing, and that goes directly to your phone, so you can track this. And on the one hand, people might say, well, that's great, you know. On the other hand, it makes people extremely conscious of what's going on, and can contribute to wanting, you know, prescription meds, or it contribute to anxiety around a milk supply. When I was breastfeeding, one of the pieces of advice I was given was, you don't know how much milk is in your breast, you know, because when you're a new breastfeeder, you feel your breast, you think, I don't have any milk, because your breasts were probably swollen and now they're not. And I think that all of these things contribute to the anxiety of people. And certainly all the mothers mentioned things like this, you know, that they were super conscious and they couldn't relax. And you know, I'm not sure how you thread all those needles. It must be a very hard job for breastfeeding support people.
Well, and at that point, I know we have about a minute left, and I'm thinking we want to share that this is a beginning conversation. We are working hard, because I see there was a question about what's our understanding of what family doctors know, and rewatch the recording, because Janet did mention a bit, or go find her thesis and you can actually see the statistics of how they reported on the survey, their understanding of domperidone and what they use. But we are also planning a 90-minute panel presentation sometime in the later spring, early summer, on domperidone with the Women's Health Research Cluster. So I put my Twitter handle at shcampbell27 in. Everyone who attended today will be sent the link to the recording. It will be posted on the UBC School of Nursing website. The blog is available. The last thing I shared was my website, where I have information. My research team at UBC School of Nursing has created 5 open education resources. The module 3 on effective breastfeeding totally deals with low milk supply. It has the resources, you know, to domperidone. These are for practitioners, for family members. I want to thank all of you in the audience who already work so hard for our parents, and just express again what a thrill it's been to work with Janet on this project that she has been passionate about, and the work that she's doing around policymaking across Canada to make off-label prescription using more accountable, but especially for our vulnerable new mothers making domperidone. So
I want to thank you for attending, and also for the great questions. And please follow up with me if you want to have more discussion. And I welcome, you're looking at my thesis, which is on Circle. Just use my name as the link, and you'll find a lot more information and results from the surveys and the mothers' interviews, plus comments from midwives, mothers, and physicians who are most of whom are using domperidone. So I think we'll answer some other questions as well.
Well, great questions in the chat about when is the manuscript coming out and can we write for UBC CPD, and Swati, we will be incorporating components of this into the 10 cyber patient modules we're creating right now. So yes, my target tends to be the healthcare practitioners because I think, and supporting them when they are new parents to get the breastfeeding help they need so that then they can advocate for their patients, because sometimes the attitude and the lack of support they have gotten affects how they counsel new parents.